test them, the levels are going to be normal, right? It's going to be a false negative. So that's why you would be more inclined to test maybe an IgG variant of the tissue transglutaminase antibody in a patient with celiac disease and IgA deficiency, just for example. Okay, so that's the concept. So that's why there is potential here for false negatives. Okay, so kind of a circuitous full circle here, but bottom line is the reason why D is not the right answer is because, again, it's not the IgA that's mediating the enzymatic destruction. This is something that you might see in a celiac disease patient, but not in a patient that's undergoing anaphylactic shock, especially because the anaphylactic shock is due to IgA deficiency. You don't have IgA antibodies, so IgA can't be mediating enzymatic destruction, if that makes sense. Okay, all right. Kind of a complicated video, but a lot of really key concepts here that you should be familiar with. Hey everybody, Dr. Viso here. In this video, we're going to talk about transplant rejection, and this is a pretty big video. A lot of topics integrated here, so we'll talk with just some basic principles of transplantations to start. We'll go through the different types of transplantations, talk a little bit about graft versus host disease, and then we'll recap this all kind of like we've been doing with some of the last chapters. And finally, we'll talk a little bit about some of the immunosuppressants that can be particularly high yield, as well as some of the biologic immunotherapy. Just to get things started, starting off pretty simple here, when we're talking about the principles of transplantation, all of these different terms have to do with where a donation is happening from. Okay, so let me show you what I mean. So in general, we have a donor. Okay, we have a donor and we have a recipient. And if you've been following along from the previous videos where we talked about red blood cell transfusions, for example, we talked about the same terminology, right? It's a donor and a recipient. The only difference was we were talking about transfusing blood or platelets. Here we're talking about transplanting an organ, essentially. And so a lot of the times we're going to talk about this transfer, whether it's a kidney or skin or whatever it is, we're going to say that it is a graft. Okay, so essentially the donor is going to be giving a graft to the recipient. Now, who the donor is, who the recipient is, that's where all of this terminology comes into play. So let me show you what I mean. So for example, let's just say that, we have a patient that has a really bad sacral wound ulcer, okay? And sometimes what we do is we would put a flap over that sacral ulcer, right? Because we don't want it to get infected. We don't want that patient to get osteomyelitis, right? So we can take skin from the same patient and put it over the ulcer. So what I'm essentially saying here is the same patient is the donor and the recipient. The patient is simply donating skin, maybe from their thigh or their leg, and that skin is then going to their sacral wound ulcer. Okay, so in this situation, the donor is the recipient. And so the term for that is an autologous transplant. Okay, so it's the donor is the recipient. So it's donor to self. And what I would call this type of graft, would be an autograft. And again, that means that the donor graft is going to themselves, maybe just a different part of the body potentially. All right, so the next situation, let's say that I have a patient that's donating a kidney to another patient. Okay, so here's my patient one. They're donating a kidney to another patient. Okay, so here's a different patient and they're donating their kidney, right? That's the graft. It's going to this patient. Okay, now because we have two different patients here, unless they're genetically identical, there's going to be some differences in their HLA antigens, which I'll talk about in a second. Okay, but the point is that these are two genetically distinct individuals. And so this type of transplantation is called an allogeneic transplantation. Okay, so that's an allogeneic transplantation. We're donating an organ in this situation to a non-genetically identical individual. All right, and so again, going with this prefix here, auto, right? Previously, this would be allo, right? This is an allograft. Okay, so this would be an allograft. Okay, so this is the type of graft would be an allograft when it goes from one person to another if they're not genetically identical. Now, in a situation if they were genetically identical, okay, that would be if you had, for example, two patients potentially that were twins, right? Particularly monozygotic twins, right? So if you had two patients that were monozygotic twins and you had one patient donate some tissue to another, then we would call this an isograft. Okay, iso meaning same. They're genetically the same. Okay, so that would be isotransplantation, donation to a genetically identical recipient. Now you're not going to see, the isograft mentioned quite as frequently because again, an isograft, it has to be between genetically identical individuals, and it's really only going to be the case in a board question where they're talking about monozygotic twins. So most commonly in a board question, you're talking about allografts. In general, when you talk about transplant rejection, you're not really going to be talking about rejection in these first two categories, right? So the autologous transplantation, the isotransplantation, there's not any differences in the genetics between these individuals. So we don't expect there to really be much rejection. Rejection comes because either the donor or the host is sensitized to some new antigens. Those antigens are going to be the HLA molecules on the cells that are being transplanted, or it could be on the host cells as well, which I'll talk about as we go through this. Now, the last one I just want to put on here before we wrap this up, because occasionally you'll see this come up. Let's just say that we're transferring tissue from a different species to a human, okay? So to some patient. So this happens a lot when you talk about certain types of heart valve transplants that aren't necessarily allogeneic, right? They're not coming from human to human. It's coming from a different species, usually bovine heart valves you'll see occasionally. But when you see this terminology for the graft here would be a xenograft. Okay, so xenograft is when we're talking about donor grafts to a different species. Okay, so that's a xenograft. And again, the biggest one on here is going to be the allogeneic, right? The allogeneic is the big one because that's how the majority of these trans rejections are going to occur. They're going to occur because there wasn't complete matching between the donor and the recipient. Okay, so this is the majority of what we're going to be talking about. Now, how do these antigens even cause a rejection to begin with? Well, remember, the HLA genes will code for our MHC molecules, okay? And we talked a little bit about MHC being on the surface of all nucleated cells, particularly MHC1, right? MHC1 is on the surface of all of our nucleated cells. And the thing that we talked about earlier too is MHC1 can be remembered by remembering that it's just one letter after the HLA molecule, whereas MHC2 can be remembered because there's two letters after the HLA molecule. And these are all different variants of these HLA molecules. And so there's a lot of diversity and distinction between them. The point being though, let's just say that, we did donate some organ from one patient to another. There's a couple different things that can happen, right? So let's just say that this recipient here, right? This recipient might recognize MHC molecules on that transplanted kidney, for example, right? They might recognize MHC1 and say, hey, this MHC1 has a different HLA than the HLA that we have, right? I'm doing gross oversimplification here, but they might have slightly different HLA molecules. And so the T cells in this patient, particularly, right, what's going to bind MHC1? It's going to be CD8 positive T cells, right? Rule of eights. So the CD8 positive T cells in this patient could attack this graft. And it can attack this graft, this allograft, right? It can attack it at these HLA antigen, at the MHC1 antigens. Now, the other thing that can happen is we can also have antigen presenting cells that say, hey, look, these HLA molecules that have the two letters after the HLA, these HLA antigens are different from our HLA antigens. Again, but this is now at MHC2, right? This is going to be antigen presenting cells. And again, if you're not familiar with some of this, go back and watch some of the videos on T cells that we've talked about. We're really building on the knowledge from this whole video series to get through this concept. But the idea here is you can have antigen presenting cells bind this MHC2, present this to CD4 positive T cells, right? CD4 positive T cells can then get activate B cells through CD40 ligand, and you can generate antibodies against these antigens, okay, via MHC2. Okay, so this could be potentially more of a humoral response. But we'll get into all of the details on this as we proceed, but that's the concept. That's essentially what we're talking about. So the big take-home points here, remember, allogeneic is what we're primarily talking about. Two genetically non-identical recipients, right? They're both humans, same species, that we're having one organ donated to another. If the patient was genetically identical, very unlikely for this to happen because they're going to have all of the same HLAs, right? So you're not really going to see a significant reaction there. And if it's autologous, it's going from the donor to self, essentially. So it's the same person. So generally, we're talking about allograft transplantations. And again, it could technically happen here with the xenografts as well. They just don't tend to come up as much in terms of the board questions. All right, so we're going to talk about our first type of transplant rejection here. So this is going to be the hyperacute rejection. Now, before we go any further though, I want you to just kind of organize this in your brain a little bit because we just talked about the acute blood transfusions not too long ago. And remember, the acute hemolytic reaction, okay, so we kind of just talked about this. The acute hemolytic reaction primarily had to do with this, red blood cell major antigen incompatibility, right? That was the concept. The concept was there was some mismatch in the A, B, and O antigens. And you can go back and check that video out. We go into that in great detail. But that was the concept of an acute hemolytic reaction. Now there's acute hemolytic reactions, there's delayed hemolytic reactions, right? But there's also acute transplant rejection there's chronic transplant rejection, there's hyperacute transplant rejection. And so you have to kind of organize these in your mind and understand that in the hyperacute transplant rejection, you can see red blood cell incompatibility, and we'll explain why that is in a second. This is essentially going to be very similar to the acute hemolytic reaction, though, that we talked about, if it presents this way. The pathophysiology isn't very different from what we talked about with acute hemolytic reactions. The only difference is we're transplanting some tissue, right? Allogeneic transplant usually. And with that, there might be some HLA incompatibility and potentially some incompatibility in the red blood cells and the red blood cell antigens. Now, of course, what we would normally do to prevent this is we would do a type and screen or direct Coombs test, testing to make sure we're not going to end up having an acute hemolytic reaction or a hyperacute rejection. But the point that I want to make is that you see this with both hyperacute rejections and acute hemolytic reactions. It's the same pathophysiology. This tissue that we donated, we didn't type and screen those red blood cells to see if they had markers on them the recipient might already have antibodies against. Okay, and again, we talked about this in great detail in the acute hemolytic reaction. I don't want to belabor the point here, but the reason I bring this up is because there's also an acute transplant rejection. Okay, so there's also an acute transplant rejection. And the acute transplant rejection is not the same as these two. Okay, so this is not the same as these two. This is a completely different pathophysiology, and it happens on a completely different timeline. Okay, so my point is, I don't want you to confuse acute hemolytic reactions with acute transplant rejection. That's the big point. So it's just kind of noting these things so that you're aware of them, noting them in your mind so that when you come into those situations, you don't get confused or tripped up by it. Okay, but the hyperacute rejection is very similar to the acute blood transfusion reaction. The concept here is, when we talked about transfusion reactions, so again, I have my donor, I have my recipient, right? And essentially in a blood transfusion, right, I would be donating this blood, and this recipient might already have anti-A antibodies, right? Especially if this patient didn't have A antigens on their red blood cell surface. So if this patient was, blood type B, for example, this patient might not have A antigens on their red blood cells, so they'll probably have anti-A antibodies. And so when this donor red blood cell comes in here, right, what's going to happen? Well, it's going to get marked for destruction by preformed antibodies. These antibodies already exist. We don't have to wait to undergo class switching to form them. So these antibodies are going to bind immediately to the surface of this cell, mark it for destruction, and then we're going to end up with most likely complement-mediated destruction of these red blood cells. And because we'll have an antibody here sitting on the surface of this cell, right? If I draw it in here, I'll have an antibody sitting on the surface of this cell, right? This is going to be a type 2 hypersensitivity reaction, right? I'm marking those red blood cells for destruction. And so this is essentially what's happening with a graft, right? When I donate tissue, it's the same concept. So if you can imagine, instead of this being a red blood cell, let's just say that this is some tissue, okay? So maybe I'm donating, I'm just gonna draw a kidney in here, right? We draw some kidney in here, and on this kidney, there's antigens. There's HLA antigens. There might also be some blood in that kidney, potentially, or when that transfusion happens, there might be some blood that's transferred with it. Okay, so you have your HLA antigens, you have your red blood cell antigens, right, that are all gonna be on this tissue, right? And so when I donate that tissue, the same thing can happen, right? I can have antibodies that are preformed against these HLA antigens. Instead of it being anti-A antibodies, I might have anti-HLA antibodies to specific HLA molecules that are going to be on this donor's graft, right? This is why we have to perform HLA matching, just like we have to cross-match red blood cell antigens, right? Because if we don't match the HLA markers and we start donating tissue, that host might already have antibodies to that graft. And so what's going to happen here? Well, it's the same thing as what we talked about with the red blood cells, right? These antibodies are then going to bind to the surface of the donor's graft, and this is going to lead to complement-mediated destruction. So let's just talk about this here. So again, it's destruction of the donor graft, and this is where you have to be careful. Again, destruction of the donor graft by recipient preformed antibodies, right? By recipient preformed antibodies. Again, this is a type 2 hypersensitivity because I'm putting antibodies on tissue, right? I'm putting it on the red blood cells, or I'm putting it on the kidney parenchymal tissue, or whatever it is that I'm donating. Because these antibodies are preformed, in other words, right, we didn't really do a good job of matching the HLA antigens or matching the red blood cell antigens. This is going to lead to a very rapid onset, which is why it's called hyperacute. Now, in a board question, the way that they'll ask you about this is they'll say that, a surgeon just transplanted this kidney, and as soon as there was, for example, an anastomosis created, or the blood from the recipient was then sent to that organ, what will happen is an immediate edema to the graft of the tissues. Okay, so there's an immediate reaction. As soon as this recipient's antibodies get to that kidney, it's marking it for destruction. Complement cascade is set off. So we're talking about something that's happening, again, within minutes of the graft placement. It's going to happen in the operating room. Okay, here, let's write that down. It's going to happen in the OR. Okay, so this is going to be classically presenting as they literally put that organ in the patient, it's immediately being rejected. And not only is it being rejected, this complement-mediated destruction, right? If I zoom into this kidney, okay, if I zoom in and I look at a blood vessel going through this kidney, okay, and I establish perfusion, right? This is all the recipient's blood now going through this blood vessel to supply this kidney. The antibodies here are immediately going to start to bind, right? The antibodies are going to start to bind and recognize this HLA mismatch all around this kidney tissue. And what's going to happen is we're going to get complement-mediated destruction. So complement is going to start destroying the tissue around here. We can get a little bit of an inflammatory reaction potentially, but eventually what's going to happen is from all of this endothelial cell destruction, it's eventually going to block off this vessel. Okay, so now blood can't get through this kidney tissue, and we know that if we can't get perfusion to an organ, what happens? Well, we end up with ischemia. Okay, so we end up with ischemia because we can't get blood through this organ. And this whole thing here is going to clot, right? This blood here isn't really moving, so it's going to clot. You can get thrombosis of these vessels. Okay, and so what is that going to look like when you see a blood vessel that has dying tissue around it, right? Particularly these smaller vessels that have smaller luminal diameter, they're going to have fibrinoid necrosis, right? So you're going to see thrombosis, fibrinoid necrosis of this vessel. The tissues will have ischemia. You're going to get necrosis immediately of the graft, and that graft has to go, has to come out. And again, the way that we minimize this is we make sure that the HLA antigens in the donor match the HLA antigens in the recipient, just like we do with red blood cell transfusions. It's the same thing as we talked about with ABO incompatibility. It's just with HLA antigens. And it can also happen with ABO incompatibility here as well. It can be multifactorial, right? But the big thing is going to be the HLA antigens. We want to make sure that those are matched up. All right, let's talk a little bit about acute rejection. Now, the first thing I want to say here is, again, we just talked about this in the last video. Don't confuse acute rejection with acute hemolytic reactions with blood transfusions, right? There are two different things. The acute hemolytic reactions with blood transfusions are type 2 hypersensitivity. Pretty much they're caused because of preformed antibodies. They're going to happen a lot faster, and they're more synonymous with the hyperacute transplant rejections. Okay, so that's number one. Number two, in all reality, hyperacute transplant rejections are pretty rare because usually we're going to be looking to match HLA antigens right before we go putting an organ in somebody. So you don't really see them a lot. However, the acute transplant rejection is actually quite a bit more common. It still results from HLA incompatibility, but maybe not to the same extent as the hyperacute rejection. The difference here is, remember, with hyperacute rejection, we're talking about preformed antibodies. We already have those antibodies, we just weren't matched really well. And so immediately those antibodies started attacking that graft, right? And caused, within minutes, it caused thrombosis of the vessels around it. It caused ischemia and necrosis of the graft. Now, an acute rejection is going to happen on a longer period of time. It's going to be a rejection that happens within weeks to months. And because of this, it's not because of preformed antibodies, right? If it was preformed antibodies, just like we see with type 1 hypersensitivity reactions, happens immediately when that IgE is on the mast cell. Just like with acute hemolytic reactions, right? We had antibodies preformed, things start getting destroyed right away, possibly even during the transfusion. Here, though, it's going to take time for that reaction to happen. So let's just look at a couple scenarios to kind of get an idea of what we're talking about. So again, we have some donor. Okay, so here's my donor. And I'm just going to draw, we'll just do a kidney again, right? We did a kidney last time. So the donor is going to give a kidney to the recipient. And here's my recipient. Now this time, I don't have preformed antibodies to the HLA antigens here. But what can happen is, after this recipient gets this kidney, okay, after that comes in here, initially we might have some antigen presenting cells in this recipient. Okay, so I'm just going to put antigen presenting cells. And again, I'm going to go through this a little bit fast. And the reason is because we actually talked about this probably 5 or 6 times during the immunosection. So like I said, go back, check out some of those previous videos. But essentially what we're talking about here is this antigen presenting cell is coming from the recipient now. Okay, remember, this kidney came from the donor. I'm trying to keep it color-coded for you. And so what can happen is this antigen presenting cell can say, hey, look, there's some HLA antigens on here. And then it can take a piece of this HLA antigen, and then it can present it to a T cell, right? So it can present this HLA antigen to a T cell. Again, the recipient's T cells can recognize this. Now, of course, this can go a couple different ways, and we talked about this in great detail already in the video series. But again, when this antigen presenting cell presents this HLA antigen, it can release certain substances, right? It can release interleukin 12. And if it releases interleukin 12, it's going to cause this T cell to become a T helper 1 cell. And then what's that T helper 1 cell going to do? It's going to release interferon gamma, right? And that interferon gamma is going to cause macrophage activation. And these macrophages, and what are they going to do? They're going to go and they're going to attack that tissue, okay? But again, this whole process takes time, right? This T cell response takes time. This process here, right? This process here, along with potentially CD8 positive T cells, right? If you factor in some CD8 positive T cells here, so we're just going to put T cell, CD8, right? So you might have some CD8 positive T cells that also recognize these antigens and also start destroying the tissue here. And this whole process here really is going to be largely driven by destruction of this graft by macrophages, right? From a T helper 1 response and CD8 positive T cell activation. And we talk about this very frequently as a cell-mediated response. When we have cell-mediated responses, that's very similar to a type 4 hypersensitivity, okay? So that's a cell-mediated response. That's one possibility of something that can happen with this graft. Now, if this happened, what would you expect to see on histopathology? Well, you'd expect to see a whole bunch of T cells at the site of the graft, right? So CD8 positive T cells, potentially these are CD4 positive, talked about that, T helper 1 cells. You'd expect to see a whole bunch of these, and macrophages too, all around the graft. And so a good image of that is depicted here. You can see this is really a significant lymphocytic mononuclear infiltrate, right? It's infiltrating, in this case, the lungs, right? You can see these are all your alveoli, your alveolar tissues here. And when you see a bunch of lymphocytes in the tissue here, that's very consistent with either an acute or potentially a chronic transplant rejection. You might be saying, well, how do I tell the difference? Well, you look at the timeline, right? So acute rejections are going to be usually less than 6 months, weeks to months. If you're talking about a chronic rejection, it's going to be like a year out at least. Okay, but they'll look similar on histopathology. There are a couple differences we'll talk about. Things like fibrosis or more chronic inflammation is going to be more consistent with chronic rejection, right? The acute rejection is going to be more consistent with things like vasculitis. But again, if it's cell-mediated, it's very classic to see this lymphocytic infiltrate. Again, when I say cell-mediated, I'm talking about this process that we've gone through a few times now, but essentially macrophage and CD8 positive T cell destruction of the graft. And that's what you're seeing here. All of these blue dots that you're seeing throughout here, this is this dense lymphocytic infiltrate. And you can also see here, and you can see here, these are all red blood cells. Right? And so you also have some intraalveolar hemorrhage, probably from the parenchymal destruction of the lung here. Okay. And so, but again, what are you looking for? You don't have to be a pathologist. You're just looking for a dense lymphocytic infiltrate. Look for a whole bunch of lymphocytes everywhere, and then ask yourself, what's the timeline? Is it weeks to months, or is it, a year plus, right? Usually, like I said, less than 6 months is almost always going to be acute rejection. If it's like 10 to 11 months, you'd lean more towards chronic, or look for additional findings like fibrosis or vascular, smooth muscle proliferation, which I'll talk about in the next slide. Okay. But that's what we're talking about here with acute rejection. Now, the thing about acute rejection that's a little tricky is that this can be a cell-mediated response, but it can also be a humoral response. But it's usually not both, okay? So it's kind of like it's one or the other. Now, this is the cell-mediated response like we just talked about. Now, a humoral response would be a little bit different. So let's do the humoral response here on the bottom. Okay, again, we have our donor donating a kidney to our recipient. Okay, now the difference here is, again, there might be some antigens on here, some HLA antigens that are recognized by the antigen presenting cells. Okay, so the antigen presenting cells will recognize these. One good question here is, if the antigen presenting cells recognize these, what type of HLA are they recognizing? Well, it's probably going to be HLA-2, right? If it's an antigen presenting cell, it's probably going to present this to CD4 positive T cells. And if it does, we know that it's going to be MHC class 2, which means it'll be an HLA antigen that has 2 letters after the name, right? So these are all like the little intricacies of putting this all together. But again, the antigen presenting cell will identify this HLA antigen. It's going to take that HLA antigen and present it probably to a T cell again. Okay, probably to a T cell, probably a CD4 positive T cell, right? Especially if this is MHC2, right? According to our rule of 8s. And so then this T cell, if we're going down a humoral pathway, would probably become a T helper 2 cell, right? A T helper 2 cell can then go on to bind with B cells and activate B cells to undergo class switching. Okay, and we talked about all of this in the previous videos, right? Driven by CD40 ligand. And these B cells will then convert into plasma cells and start making a bunch of antibodies, right? They'll be turned into antibody factories. And this whole pathway here is going to be the humoral response. And a humoral response is going to be more consistent with a type 2 hypersensitivity. Why is that? Well, because we're making these antibodies. Where are these antibodies going to bind to? They're going to bind right to these antigens on the graft, right? So similar in some ways to the hyperacute rejection where we had preformed antibodies that bound to the graft. In this case, the difference is the antibodies are not preformed, right? We're going to have to take some time to form these antibodies and then have them bind to the graft because of potentially some HLA incompatibility or mismatch. But again, it takes time for that to happen. It takes time for the T cells to become T helper 2s, to then bind to B cells, activate them, undergo class switching, and eventually make IgG antibodies against the graft, as opposed to having preformed antibodies. So that's the major difference. But again, it's kind of the same mechanism after that point, right? It's really just type 2 hypersensitivity, complement-mediated destruction of the graft, largely driven by complement. Now, would you see, if we went down just a humoral response, what are some things that can help you distinguish that from the cell-mediated response? One of the big ones is we can look for complement in the graft. Remember, when we're talking about a humoral response, we're talking primarily about complement-mediated destruction. So, right, if I tag something for destruction and then I start having complement bind to this, right, eventually leading to a membrane attack complex to destroy the graft, well, that's going to be a little bit different than if I just destroy the graft using CD8 positive T cells and macrophages. Okay, so what we would do is we can look for complement markers. So if you use specific complement markers, one classic one is C4D. Okay, so if they tell you they use a complement marker on a histo slide, right, or immunofluorescence with a complement marker, and it's lighting up and it's positive, well, then we think more about humoral rejection. However, if that complement marker is negative, right, if I'm not really getting anything when I use the complement markers, in other words, it's saying there's really not a lot of complement here, it's probably more cell-mediated destruction. Remember, with acute rejection, it's usually one or the other. Okay, it's usually not going to be both. So you're going to have destruction from one or the other classically, and that's particularly important to remember here. What's this going to present with? Well, edema to the graft tissues, so all the swelling, all of the inflammation, and eventually you'll have some deterioration of the function of that organ. In our case, we're talking about a kidney. What are some things you would see in a board question that would make you think, or even in real life, that would make you think that this patient potentially has some rejection of a kidney? Well, you would probably see an increase in their creatinine, right? The filtration, the GFR would be decreasing or declining. You probably see an elevation in the BUN as well. You probably have decreased urine output, for example, right? These are all things you want to look for in a board question. Again, it depends on the organ being transferred. And again, the classic thing here is we want to make sure we're matched from an HLA perspective, and we also can add in some immunosuppression. Now, if you have an acute transplant rejection, what you can do in these patients is you can kind of quote unquote blast them with high dose glucocorticoids and try to basically eliminate this immune response acutely. Okay, that's one option. It might not always necessarily work, but you can also have these patients on maintenance immunosuppression therapy, hoping that this doesn't happen. All right, so what about chronic transplant rejection? So the big difference here between the acute transplant rejection is going to come in a couple different places, but it's not significantly different. Okay, so the first thing is, again, we're talking about HLA incompatibility, right, which is pretty consistent with what we've said so far. The timeline is a little different here, though. It's going to be more months to years. Usually 6 months and on is a good way to kind of go about thinking about chronic rejection. So I would say when you start to get greater than 6 months, and now this patient is starting to present with some signs of transplant rejection, then we think more about chronic rejection. Now, what's the difference? Again, we said there's a couple key differences. One is the timeline here. The other one is this word right here, and, right? So you can sometimes see cell-mediated and humoral responses kind of integrated together in the chronic rejection. Whereas when we talked about acute rejection, we're saying usually it's one or the other. Okay, and again, this is the same thing that we talked about in the last slide. So I won't go through it all again, but again, you can have a cell-mediated response, humoral response. Remember, your cell-mediated is primarily type 4 hypersensitivity, humoral is type 2 hypersensitivity. And again, the idea is there's some cytotoxic destruction to the graft related to macrophages, CD8 positive T cells, and then eventually antibody production post-class switching, where you're going to have IgG antibodies inducing complement-mediated destruction of the graft. Okay, talked about this all in the video on acute rejection. And again, the presentation is pretty much the same, right? It's not a huge difference from acute rejection. Really, we have to just focus on the timeline, and then remember, mechanism can involve both the cell-mediated and humoral responses. Now, in terms of the histopathology, this can be a little different. There's a couple key words I want you to look for, okay? The first one here is fibrosis. When you see fibrosis, just in general, okay, it's almost always chronic inflammation, right? Fibrosis, TGF-beta, a lot of these things that we've talked about already are very classic terms terms to call your attention immediately to something like a chronic disease process or a chronic rejection. It's been happening over a long period of time. There's chronic inflammation there. Eventually, what will happen is if we're not acutely cutting off the entire blood supply to an organ, we'll start to have some VEGF, right? We'll have some vascular endothelial growth factor potentially being released. We'll have some vascular smooth muscle proliferation to try to reestablish blood flow to this tissue. But by this time, it's already atrophic. It's not necessarily completely ischemic, but it's on its way down. It's not an acute destruction of the organ. It's just that the recipient's immune system is just like hacking away at that organ. Okay, that's one way to think about it. Now, in terms of the management, in these situations, usually when you catch chronic rejection, you just have to take it out. We try to prevent it, again, using things like immunosuppression, all the things that we talked about in the last video. But again, the big things to distinguish acute versus chronic rejection, because this is what you'll typically have to do. Number one, remember the timeline, usually greater than 6 months. If you start getting into the years in terms of how long this patient has had this transplanted tissue, in those situations, usually you're talking about chronic. The key word, number one, is going to be fibrosis, right? Usually interstitial, right? Some vascular smooth muscle proliferation that's going to take, time to happen as there's worsening perfusion potentially to this organ. And it's going to be atrophic, right? It's going to be shrink in size, and usually we'll have to remove the graft in these patients. But that's what we're looking for. And remember that you can get humoral and cell-mediated responses in the chronic form of transplant rejection. All right, let's talk a little bit about graft versus host disease. Now, this is probably one of the highest yield slides of this chapter, and so I really think it's one of the ones that we're going to spend a little bit of time on to make sure we're sharp on this, because some of this can get a little confusing, but if you understand the last few slides, it might make a little bit more sense here. So let's just go back to our basics here. So let's just say we have some donor, and let's just say that we're doing a stem cell transplant from this donor's tissue. Okay, so we're going to do a hematopoietic stem cell transplant, potentially from the bone marrow here of this donor, and we're going to give it to the recipient. Okay, so that's the idea. Now remember that when you do a hematopoietic stem cell transplant, okay, when you do this, a lot of these cells are going to be very rich in lymphocytes. Okay, so we'll just put rich in lymphocytes in this region. So when this donor gives this tissue that's rich in lymphocytes to the recipient, these lymphocytes might start, floating around the blood and eventually might recognize some of the tissues here in the recipient. Okay, so let's just say that here's my recipient, and I'm just going to draw my GI tract here in the recipient, and maybe these lymphocytes are, in the blood vessels around the intestines, for example, and they might recognize some of the HLA antigens on the recipient as foreign. Okay, so here's all these lymphocytes that are coming in here from the donor, and they might be floating around in the blood vessels and recognize some of these HLA antigens, particularly the CD8 positive T cells. Okay, so the CD8 positive T cells are the killer cells, again, coming from the donor, coming from this hematopoietic stem cell transplantation, right? These lymphocytes might recognize the tissues in the recipient, right? So we said in the intestines, potentially in the skin of the recipient, right? So in the skin. So these lymphocytes are going to start to recognize some of this tissue as foreign. Again, probably because there could be some, sensitization or HLA incompatibility that's causing this. But again, these lymphocytes, usually going to be CD8 positive, are recognizing these cells. Now, if they're recognizing all of these cells in the recipient, they're probably recognizing MHC1, right? Especially if they're CD8 positive. Because remember, all nucleated cells are going to have MHC1 on them, okay? And so the MHC1 on these recipient cells are getting recognized and eventually getting destroyed by this donor's T cells, essentially. And there's a lot of these T cells that are being transferred, right? We already said that the bone marrow is going to be very rich in lymphocytes. And so again, the big difference here from what we talked about before is in this situation, it's the donor's T cells, not the recipient's cells. It's the donor's T cells that are damaging the host tissue. Okay, before when we said acute rejection, hyperacute rejection, chronic rejection, everything was flipped. It was the host, right? It was the recipient that was damaging the donor graft. In this situation, it's the graft that has the T cells in it that then kind of come out and destroy the recipient's tissues. And so this is going to be a cell-mediated response, again, because it's driven by the T cells, not the T cells of the recipient, again, the T cells of the donor. And because of that, it's going to be a type 4 hypersensitivity reaction. We're primarily talking about CD8 positive T cells. Now, the onset for this is completely variable, okay? It's not particularly high yield to know that, but it is high yield to know that when you see a board question, they say this patient got a hematopoietic stem cell transplantation, you immediately should think about graft versus host disease. Now, if they said that this patient had a kidney transplant or renal transplant, I wouldn't jump to this, right? I wouldn't think of this necessarily. But when I see hematopoietic stem cell transplantation, that's my first clue. That's my first clue that says, hey, we're probably dealing with graft-versus-host disease. I don't know for sure yet, but I'm going to look for some other clues in the question, which we'll talk about in a second. Before we talk about that, though, there is another situation that can kind of go either way. Liver transplants. Now, livers are also kind of rich in the lymphocytes. Okay, so if they tell you that the patient had a liver transplantation, this is also very classic for causing graft-versus-host disease. Kind of one of the classic things you'll see here, and this is your way to distinguish this, and this might also be getting into a bit of the details here. But let's just imagine if you're trying to say, hey, is this graft-versus-host disease, or am I dealing with something like an acute or chronic rejection potentially? Well, you have to look at the liver function. Okay, so you have to look at the liver function. Now, if we think about this, right, if the donor gave the liver to the recipient, and the recipient is rejecting it, right, from either acute rejection or chronic rejection, the recipient starts making antibodies against it, marking it for destruction. What's going to happen to that liver that the donor gave the recipient? It's going to get marked for destruction. It's going to get destroyed. We already said it's going to have either fibrosis, right? It's going to become atrophic. It's going to have a decline in function, all the things that we talked about, right? That liver is going to get damaged. If I put that in the recipient marks it for destruction and destroys it. That liver that was donated, that graft, is going to get destroyed. We might have to remove that graft. So if we're talking about an acute rejection or chronic rejection, like we talked about before, where the recipient or the host damages the donor graft, in these situations, we would expect to have a decline in the liver function, right? We'd have a decline in that liver function because it's getting damaged. So we'd see elevations in the AST, in the ALT. We'd see jaundice, scleral icterus, right? Signs that this liver is not working, right? Now, the other situation is, let's say that this donor, again, donates the liver, and let's say this liver is really rich in these lymphocytes, right? And these lymphocytes are going to recognize the recipient essentially as foreign, right? They're going to recognize the tissue potentially in the intestines, potentially in the skin as foreign, and they're going to start to destroy those tissues. In that situation, okay, in the situation of graft-versus-host disease, right? I'm going to put graft-versus-host disease, which is what we're talking about here. What would happen to the liver function? It's going to be normal because the liver's not getting attacked. The liver came from the donor. The lymphocytes in the liver come from the donor. The lymphocytes in the liver from the donor are not going to attack their tissues that they're genetically identical to. They're going to attack the recipient's tissues in which they're not identical to. So in graft-versus-host disease, that liver function, it should be normal, right? It should be normal. What's not going to be normal is the rest of the presentation. The host tissues are getting attacked. The recipient's tissues are getting attacked. So the recipient is going to have things, if our skin's getting attacked, we're going to see a rash. A classic rash that we'll see in graft-versus-host disease is a maculopapular rash. It might be diffuse, right? Normally, if you have transplant rejection of a graft, it's usually local to that area, right? But if you see diffuse issues in this patient, diffuse pathology, right? Maculopapular rash. If you see this patient has abdominal pain, nausea, emesis, diarrhea, these are all things that might signify potentially this is more of a graft-versus-host disease. Again, if I transplanted the liver and the liver caused this, the liver function would be normal. Now, again, like I said earlier, though, the classic pathology is a hematopoietic stem cell transplantation. So you can see all of this, again, in a hematopoietic stem cell transplantation. And in that situation, you might see jaundice and an increase in the ALK-Phos or an increase in the liver enzymes. Because if I do a hematopoietic stem cell transplant, the liver's fair game, right? But if I transfer the liver, then I know that the donor lymphocytes aren't going to attack their own tissue. That's the point I'm making, okay? So the point is, if you have a hematopoietic stem cell transplant, liver's fair game, right? If you transfer the liver, though, these cells are not going to attack where they came from. And that's the point. They're already genetically identical. So just remember that. So you would only really see this if the patient had a hematopoietic stem cell transplantation. That's the point I'm trying to make. Again, pancytopenia, this is also possible, right? The recipient cells can get destroyed by these lymphocytes. Okay, so it's a diffuse presentation. That's the point. We're attacking tissues all throughout the recipient. The classic ones are going to be dermatologic and intestinal. All right, and again, we're going to see lymphocytic infiltration of the host specimen. Now, there's something in here that's subtle that's important. Okay, we already said you can see lymphocytic infiltrate in acute rejection, chronic rejection, but the key is the host specimen. So let's just say this patient has a maculopapular rash. You do a biopsy of the skin. You see a lymphocytic infiltrate. Well, that's classic, in the right vignette for graft-versus-host disease. And you might be saying, okay, well, how does that compare to the acute rejection, chronic rejection? Well, it's the host specimen. It's the recipient's skin you're biopsying. You're not biopsying the graft. If I biopsy the graft in graft versus host disease, right, the graft isn't getting attacked. The graft isn't abnormal. Whereas with acute and chronic transplant rejection, it's the graft that has this lymphocytic infiltrate. Here, the graft is just fine. It's the host tissues you're biopsying that have lymphocytic infiltration. So again, you have to pay attention, right? What are they biopsying? Are they biopsying, this recipient's intestines because they have inflammation potentially, or the skin because they have a rash? In those situations, now we're thinking more about graft versus host disease. If I'm biopsying the graft and I see a lymphocytic infiltrate, I'm thinking more acute or chronic rejection. You might see immunosuppression, in a lot of these patients because, right, we don't want the host to destroy the graft. But here's the problem. If you start immunosuppressing this recipient's going to have a harder and harder time fighting off these T cells that are attacking its tissues, right? And so the concept is, right, as you immunosuppress this recipient, this reaction can actually get worse. So as you start to increase your immunosuppression, right, you can actually make the graft versus host disease worse. Potentially, right? Because now the recipient has less of an opportunity to sustain the damage from all of these T cells. The other thing is you can see this graft versus tumor effect that sometimes comes up. And so the concept here is, let's just say that you had a patient that had leukemia or a patient that has myeloma, for example. What ends up happening is, especially with leukemia, is you kind of have this crowding of all of these white blood cells that are being produced. If we take leukemia, for example, right? And all of these white blood cells are essentially crowding out all of the other cell lines, okay? And a lot of these white blood cells are going to be genetically similar in some way, and they're, in many cases, not functional, okay? And so they're really just taking up space and causing things like pancytopenia from the cells that actually work, okay? Because they crowd everything out, right? They're crowding. And so what you can do here, if you do a transplantation of hematopoietic stem cells to try and fix this problem, you can actually get these patients immunosuppressed enough to increase potentially this graft versus host disease. But instead of thinking about the graft attacking the host, you want the graft to attack all of these kind of non-functional crowded leukemic cells, right? And so we call this the graft versus tumor effect, right? You want it to kind of target these tumor cells or the cancer cells. And so these T cells that are coming from the graft, right, they can go over here and recognize that, hey, these cells don't have the correct HLA antigens, right? So these CD8 positive T cells can start destroying all of these abnormal crowded cells, right, or tumor cells. Now you can imagine that these CD8 positive T cells aren't selective for just the tumor, right? They're also going to destroy the host tissue. So as you increase the immunosuppression, right, you're also going to potentially increase the side effects that these patients might have with graft versus host disease, but you're doing that to try and get the graft cells to essentially attack the tumor or the underlying pathology as well. So anything beyond that is really beyond the scope of step one. It's just something that you want to be familiar with. And again, remember, all of this is really happening in allogeneic transplantations, again, where there's some potential for HLA incompatibility. We have our hyperacute, acute, and chronic rejection. And remember, in all of these three situations, we're talking about donor graft destruction. Okay, so everything is against the graft. Okay, so we're attacking the graft with hyperacute, acute, and chronic. In graft versus host disease, it's just like it says. The graft is doing the attacking, okay? It's the donor graft that's attacking the host or the recipient, okay? So that's how we kind of distinguish these. Now, these three are distinguished based on the timeline. Is it happening in the operating room? Then it's hyperacute. Is it happening around, less than 6 months or so? Then we say acute. Greater than 6 months to years out, we're thinking more chronic. What type of response are we getting? Well, remember, the hyperacute is very similar to the acute blood transfusion reactions, right, in the sense that it's humoral. The acute can be either or, okay, and the chronic is both. Okay, so that's your kind of way of remembering this, humoral or and. And remember, graft versus host disease is cell-mediated. And if you're ever in a situation where you're getting really worried because you're saying, well, I don't remember what it is, think about what's happening, right? If something happens immediately, it has to be preformed antibodies, right? It has to be, in most of these situations. So it has to be humoral because there has to be something already there to immediately cause a reaction. Whereas if you're in a situation where it takes a lot of time for the reaction to happen, well, now it could be cell-mediated. If you're looking at a histology slide and the complement is positive on the histology slide, right? They did, a complement marker or immunofluorescence, right? And there's complement everywhere. Well, it might probably humoral, right? Because it takes antibodies to activate that complement. If you're seeing lymphocytes everywhere, maybe it's cell-mediated. Okay, so that's kind of the way to think about it. Now, if it's graft versus host disease, you know it's cell mediated. It's going to be probably CD8 positive T cells that were transplanted from a bone marrow transplantation or hematopoietic stem cell transplantation or potentially a liver transplantation. Okay, so kind of all those things that we talked about. Now, again, hyperacute, we said preformed antibodies. What does that make it? A type 2 hypersensitivity, just like the acute blood transfusion reactions. If it's cell mediated, it's type 4. Again, humoral is type 2. So it just depends. You have to take this and just apply that to the type of hypersensitivity that you're going to get. Okay, remember, in hyperacute, we're in the OR, and we're seeing that this graft is turning white or it's becoming ischemic. We're looking for thrombosis of the vessels, fibrinoid necrosis of the graft. Acute and chronic, it's really about the timeline, but in general, whatever that graft was that was transplanted, there's some decrease in function. There's some edema to that graft tissue. Graft versus host disease, the host is going to have symptoms all over the place, right? They're going to have, we said classically, dermatologic manifestations are very classic. Maculopapular rash, diffusely is very classic. Abdominal pain, nausea, emesis. You can get a pancytopenia, potentially liver involvement with hematopoietic stem cell transplants. And then the histopathology we also talked about here. So just going over that again, thrombosis, fibrinoid necrosis of the graft. Again, right away, lymphocytic infiltrate is classic for cell-mediated responses. You can also see vasculitis. And then when you're thinking things like fibrosis, you're thinking chronic, right? When you're thinking vascular smooth muscle proliferation, it takes time for that to happen. It doesn't happen, in a week, right? It takes time for you to have the mediators to eventually allow proliferation of blood vessels. And then atrophy is very classic too. It's kind of this very slow decline in the function of that tissue. Okay, and again, if you see lymphocytic infiltrate on the host specimen, right? If they do a biopsy of the skin, for example, that would be more classic for graft versus host disease. Again, where is the lymphocytic infiltrate? Is it in the graft itself, or meaning that the graft is getting attacked, or is it in the recipient, right? Is the recipient's tissues getting attacked? So that's important to know. Now, the immunosuppressants in general can be somewhat overwhelming because, there's a lot of information, but I think of the immunosuppressants really, at least the high yield ones, into, two kind of separate categories. Okay, so we're going to do category 1 here. So category 1 is just about a pathway. Okay, it's a pretty straightforward pathway. There's only 4 or 5 steps to it. So going back to kind of the pathophys we've talked about before. So again, this is going to be an antigen presenting cell, and this is going to be a T cell. Okay, now we already said antigen presenting cells can present antigens, right, via MHC2 to the T cell receptors. Usually this will be a CD4 positive T cell, right? And so the antigen presenting cell binding here will then activate this T cell, right? So this T cell now has the matching antigen. This T cell receptor gets activated, right? It gets activated, and the process here involves this calcineurin. Okay, so calcineurin will help activate nuclear factor of activated T cells. Essentially what this thing does is it just increases the transcription of interleukin 2. That interleukin 2, remember we said when we talked about cytokines, interleukin 2 can, have paracrine effects at nearby cells. It can have endocrine effects at distant cells, and it can also have effects at that same T cell, right? Autocrine effects. And so the concept is, right, interleukin 2, remember, we're stimulating pretty much a lymphocyte response with interleukin 2. Everybody's going to have lymphocyte growth when I have interleukin 2 released. And this interleukin 2, like I said, can go back to this T cell for the simplicity of this diagram and bind to the interleukin 2 receptor, okay? And the interleukin 2 receptor, and we don't need to go into all the details on this, but this can eventually lead to activation of the mTOR kinase and mTOR. And again, like I said, we don't need to go into all the details, but essentially stimulating T cell growth. Okay, as well as growth of lymphocytes in general. But that's the bottom line. So the pathway started with the presenting of an antigen, right? So we presented an antigen, that's where we started, and we ended with some increase in T cell growth. Now, if you look at this, there's really 4 points that you want to be familiar with. Things aren't as bad as they may initially seem. All right, let's clear this up and talk about it. Okay, so the first one on here is the calcineurin inhibitors. Now, we already said this antigen presenting cell is going to bind to the T cell, right? It's going to do so via this MHC2 typically, and the calcineurin here is then going to be one of these mediators that's essentially going to act to increase interleukin 2 transcription. Now, if I inhibit calcineurin, right, if I inhibit this step, then I'm going to have a decrease in my interleukin 2 released. Therefore, right, I'm going to have less interleukin 2 binding to the receptors, less T cell growth. That's why these are immunosuppressants. They're essentially suppressing in this particular diagram, the response of T cells. But remember, interleukin 2 acts on B cells, natural killer cells, etc. Classic drugs here that you want to be familiar with. The first one is cyclosporine, right? Cyclosporine. And cyclosporine can bind to cyclophilin. Okay, so by binding to this molecule, it can help eliminate some of the calcineurin here, right? So it can inhibit it. The other one is tacrolimus, commonly see on the words as people just say tacro, right? So tacrolimus can also inhibit, but it binds to a different protein, FK506 BP, or binding protein. The point here is, you might be saying, do I have to know this? Well, sometimes they ask questions about these calcineurin inhibitors, which is what they're doing here, right? They're calcineurin inhibitors. And you sometimes have to know the protein they bind to. Okay, I'll kind of explain how they tee this up in a second. But the point is, the bottom line is that at the end of the day, we're decreasing interleukin-2, right? Why are we decreasing it? Because we never really activate this nuclear factor of activated T cells to increase interleukin-2 transcription. Okay, so we're kind of blocking this pathway upstream here. And so that for that reason, we have less interleukin-2 released. Now, when would you use this? Well, if you wanted to do some kind of immunosuppression, right? So immunosuppression being transplant rejection prophylaxis, preventing transplant rejection. You can also see it used in psoriasis. These are the big two. Now, I want to say that, this is not an exhaustive list of immunosuppressants, and it's not an exhaustive list of indications or adverse effects. It's really just the high yield stuff, right? This is the big stuff that you want to know. The really important thing about calcineurin inhibitors, where this kind of gets paradoxical, is that they can cause nephrotoxicity and neurotoxicity, right? They can damage the kidney, they can damage the nerves. Now, the biggest thing is the nephrotoxicity, and the reason for that is because the mTOR inhibitors, which I'll talk about in a second, there is no nephrotoxicity with those. Okay, so this is where you have to distinguish these. What's really interesting is that a lot of times, when we're using these for transplant rejection prophylaxis, the calcineurin inhibitors actually are used for transplant rejection prophylaxis for patients that are getting renal transplants, right? When they're getting kidney transplants. You'll see these patients after they've gotten their kidney transplant, they're on cyclosporine, they're on tacro, and the thing is that they can actually cause nephrotoxicity because the cyclosporine inhibitors, or I should say the calcineurin inhibitors, can cause decreases in renal blood flow, leading to decreased perfusion of the kidney, right? That transplanted kidney, and that can cause direct endothelial damage to the kidney, right? AKI, CKD, etc. So there is a component of nephrotoxicity, and that's the particularly high yield side effect. Now, the way that you distinguish, you might be saying, okay, well, these two sound exactly the same. Am I going to have to distinguish the two? Well, if you did have to distinguish the two, it's important to know that only cyclosporine can cause the gingival hyperplasia and hirsutism, right? So cyclosporine in general, if you're in a board question and you're trying to distinguish cyclosporine from tacro, that's what you're looking for. When I see gingival hyperplasia, by the way, in a board question, I'm usually thinking about phenytoin, okay? So there's certain, unique side effects in board questions that you'll see from medications that really make you just kind of jump to something. So when I see gingival hyperplasia, I jump to phenytoin. If phenytoin is not related to the question, the next thing I'm thinking about is distinguishing cyclosporine from tacro. Okay, so that's what I would remember there, because again, they both have similar effects overall. Now, the way a board question can do that is they can give you a patient that has gingival hyperplasia and then ask you, what is this? Because again, not a lot of this is on management. It's more about mechanisms for step one. So they can say, yeah, this patient's got gingival hyperplasia, right? They're post-renal transplant. Maybe they have a little bump in their creatinine. And they say, well, what medication or what's the mechanism of action of the immunosuppressive medication this patient's on? And one option might be binding to cyclophilin. Another option might be binding to FK506, right? And so that's where you have to distinguish that. If they have gingival hyperplasia, it's binding cyclophilin, right? So all right, so that's calcineurin inhibitors. All right, we're going to jump kind of to the mTOR pathway. So we talked about calcineurin. Now let's talk about this mTOR. Again, after this interleukin-2 receptor is activated, right, there's going to be this mediator mTOR that's going to kind of assist with the growth. It's like the last step that we're going to focus on in this pathway. Now, the mTOR in general can be inhibited by sirolimus. Now, the difference with sirolimus, as you can imagine, because this is more downstream, right? This mTOR is more downstream. It shouldn't necessarily have the same effects on interleukin-2 that we talked about with the calcineurin inhibitors, right? Because it's downstream. We should still be able to make interleukin-2. It's just that the interleukin-2 receptor, after it gets activated, it's not really going to do too much, right? Because we're blocking downstream from that. Sirolimus can also bind to some of these FK binding proteins, similar to tacrolimus. So that's why you have some similarity in the name, but again, it's primarily going to be inhibiting mTOR. And again, classically used for renal transplant prophylaxis, and the high yield adverse effect here is pancytopenia. The important thing, the really important thing, is that there's no nephrotoxicity, right? So when we're using sirolimus, we're not usually talking about direct damage to the kidney, right? So that's going to be very different from the calcineurin inhibitor. So that's particularly high yield. One big thing to distinguish these two that you want to remember. Now, when we're talking about these last two drugs on here, we have one that's targeting the interleukin-2 receptor. So you can imagine, we just talked about blocking mTOR downstream. If you block the interleukin-2 receptor, right, you're essentially accomplishing the same task. You shouldn't really have any effects on interleukin-2, right, because this is all kind of before this step in the pathway. The problem is now interleukin-2 won't be able to bind the receptor because I stick this antibody on the receptor. And we've actually seen this before. If you remember in type 2 hypersensitivity reactions, we have cytotoxicity when we bind antibodies, right? When we talk about diseases like autoimmune hemolytic anemia, for example. But when you think about diseases like myasthenia gravis, right, where you have antibodies, anti-acetylcholine antibodies, for example, that bind to the acetylcholine receptor and essentially block it. Right? That's a receptor binding, type 2 hypersensitivity. That's what this antibody is doing, right? This basiliximab is binding essentially to the interleukin-2 receptor, and it's blocking interleukin-2 from binding to it. Okay, and so this is the chimeric version. The daclizumab is essentially the humanized version of it, but in both situations, they're blocking the interleukin-2 receptor. If I block this receptor, I don't actually get the effects of interleukin-2 in these T cells, right? I might be releasing some interleukin-2, but I'm not actually going to be able to stimulate the interleukin-2 receptor with interleukin-2 because I block it. Okay, so again, also transplant rejection prophylaxis. You can see hypertension and edema, kind of more nonspecific. The important thing here, remembering that this is a type 2 hypersensitivity reaction because we're blocking the receptor. Okay, the last one on here is recombinant interleukin-2. And I don't want to confuse you. Recombinant interleukin-2 is actually not an immunosuppressant. Okay, so it's not an immunosuppressant. So you might be saying, well, Dr. R, why would you include it on this slide if it's not an immunosuppressant? The reason I include it here is because it's just a really good place to see this whole mechanism and see where this drug acts. What does this drug do? So essentially, recombinant interleukin-2, it's interleukin-2, right? I'm giving this patient, essentially giving this patient interleukin-2. So let's just say that I give this patient interleukin-2. Okay, so I give them interleukin-2, which is this drug L-dysleukin. And so what's interleukin-2 going to do? Well, we already know interleukin-2 is essentially going to bind to the interleukin-2 receptor, and it's going to activate it, and it's going to cause these T cells to grow. It's going to cause natural killer cells to grow. It's going to cause B cells to grow, right? We're going to activate lymphoid cells. And so that's what recombinant interleukin-2 is doing. So you can imagine this is the opposite of immunosuppressant. This is going to increase my immune response. Why would I want to give it? Well, again, if I have a patient that has malignancy, right? And we talked about this a little bit with graft versus tumor effect. We can have our lymphoid cells target those malignant cells by recognizing those cells on MHC1, right? We can recognize cells on MHC1 that have improper antigens or no antigens at all potentially and mark those cells for destruction. So if I have a more robust immune response, I'm better able to do that. This is particularly useful in renal cell carcinoma and metastatic melanoma. Distinguish this in the sense that this is not an immunosuppressant, but it does come up in these conversations where you have to kind of go through this mechanism because it's right in the middle of this mechanism that we're talking about. Now, the second kind of category of immunosuppressants are going to be the glucocorticoids and the purine inhibitors. Again, this is in my mind how I'm organizing these pathways. Let's start with glucocorticoids because I think we've talked about this quite a bit already. So glucocorticoids, we've already went through the NF-κB pathway. And again, the NF-κB pathway is really essential for kind of kicking off the inflammatory response. We're trying to get an inflammatory response that essentially generates, acute inflammatory reactants, things like interleukin-1, interleukin-6, and TNF, right? That's what we're trying to do with NF-κB. As it enters the nucleus here, impacts transcription potentially and causes an increase in transcription of interleukin-1, 6, and TNF. So that's what NF-κB is essentially doing. Now, glucocorticoids are trying to basically eliminate that process from happening. So they're going to inhibit NF-κB and the inflammatory cytokine genes. So a glucocorticoid, remember, we're talking about a steroid, so it can usually freely diffuse through the membrane here. It'll bind to a glucocorticoid receptor in the cytosol, essentially block off this NF-κB, essentially inhibit it. Okay, and so that's what you see here. The glucocorticoid bound to the glucocorticoid receptor, inhibiting NF-κB and the inflammatory cytokine genes. That's really the extent of what you have to know here, right? You just have to remember that's the primary mediator that we're inhibiting. And again, these can be used for a lot of different things. Adrenal insufficiency, we'll talk about this in the endocrinology section. Asthma, especially acute exacerbations, or even chronic maintenance therapy with inhalers, acute inflammatory states. The big thing you'll see glucocorticoids used when we're talking about transplant rejection is, like I said, when you have an acute rejection, okay, you can usually do high-dose glucocorticoids to try to eliminate that acute rejection from happening or at least damaging the graft any further. But glucocorticoids in general, you'll see in all different types of board questions. In terms of the adverse effects, we can make a really, really long list here, okay? So osteoporosis, Cushing syndrome, hyperglycemia, amenorrhea, avascular necrosis of the femoral head, also very classic. And we'll go through this all in a lot greater detail in its respective video. I'm just including it here so that we can see this in completeness sake. Now, the two big things to remember, though, is when you give a patient glucocorticoids, you're going to essentially lead to a lot of those white blood cells, like we talked about with trolley, getting released into the bloodstream. Okay, so you're going to immediately see, some people call this an artificial leukocytosis. It's basically showing that a lot of those white blood cells that were sequestered in the pulmonary vasculature are going to get released systemically. Okay, so you're going to have an elevation in the white count. You know, especially when you go on the wards and that kind of thing, you see a patient, you see a big jump in their white count, or they have an elevated white count. The first question always should be, are they on steroids, right? The other thing is, if a patient's on glucocorticoids for a long time and you just suddenly take them off, well, you've been suppressing their ability to produce glucocorticoids for so long because you're giving them glucocorticoids, right? Everything wants to stay in some level of homeostasis. And when you have really high dose glucocorticoids being given over a long period of time and you suddenly take them away, now the patient is going from having potentially more glucocorticoids than they would normally have, right, based on homeostasis, right? But now you take that away, and now they're having way too little glucocorticoids, and you can send those patients into adrenal insufficiency, which is actually one of the most common causes of adrenal insufficiency. Again, we won't have to go through all the details on that. Big ones, though: prednisone, dexamethasone, methylprednisolone, right? We can make a long list here, but that's the concept for glucocorticoids. Again, we're just going high level here. Now, when we're talking about purine inhibitors, okay, so purine inhibitors, we're talking primarily about things like azathioprine and 6-mercaptopurine. So azathioprine and then 6-mercaptopurine are the big ones that I want you to remember. So essentially what's happening here is azathioprine goes on to form 6-mercaptopurine. 6-mercaptopurine actually can compete with some of the other purine derivatives like hypoxanthine, guanine, and by doing that, by competing with them, it'll actually inhibit some of your de novo purine synthesis, okay? And we'll go into this in more detail in the biochemistry. But the enzyme here is PRPP aminotransferase, right? This is the rate limiting step in de novo purine synthesis. Again, when I'm saying purine synthesis, I'm talking about the synthesis of the building blocks of DNA. That's what we're talking about. Now, if I inhibit that step right early on, I'm going to have a decrease in the number of purines being produced, right? If I'm using something that kind of looks like a reactant here essentially, but isn't quite doing what it's supposed to do, right? It's not actually going to be a building block of DNA. That's going to kind of tie up this enzyme, right? And inhibit this process. And so I'm going to get less formation of IMP, which would be the downstream step, less guanine, less adenine essentially being formed, less nucleotides, less DNA production. Therefore, the cells that rely on high levels of nucleotides for very frequent replication, right, responding to pathogens, foreign invaders, generating a robust lymphocytic response, those cells, the lymphocytes, are going to be in a lot of trouble, right? When I give drugs like this and I block the formation of new purines, right, the synthesis of new purines and the formation of DNA, that's going to be a big problem, but it's going to be a big problem for the cells that have to replicate the most, right? If a person is fighting off an infection, these cells are going to be replicating. They're going to be going through, maturation affinity with the B cells. The B and T cells will need to generate a memory response. You're talking about things like affinity maturation with B cells. It's a lot of replication going on and a lot of transcription also going on. So when you start to take out any building block of DNA, you're going to feel the effects of it, particularly in the lymphocytes. And that's essentially what's happening here. Now, mycophenolate and then ribavirin, which I won't talk about too much here, these are both going to have a similar effect, but we're mostly going to be inhibiting the enzyme inositol monophosphate dehydrogenase, IMPDH here. And again, we'll go through the whole pathway when we talk about biochemistry. I don't want to get too off track, but essentially mycophenolate is going to act here. So it's primarily going to inhibit the formation of guanine, whereas the 6-mercaptopurine should be more of a global effect between the purines. And I want to say too, for both of these, you do see mycophenolate, in patients that have had renal transplants. But in general, I would say, especially azathioprine, 6-mercaptopurine, mycophenolate, you see these more with patients that have like autoimmune conditions like rheumatoid arthritis. And step one isn't really big on, management per se. But I would say overall, they're more classic for things like inflammatory disorder, more so than a transplant prophylaxis. Mycophenolate is probably the one that you do see sometimes with transplant prophylaxis, but just kind of keep that in mind. The other thing on here that I didn't really show in this pathway is methotrexate. So just remember methotrexate, and we'll go through this, like I said, in the biochemistry section. But methotrexate, that's represented here as MTX. So methotrexate is going to inhibit dihydrofolate reductase, okay? Kind of like trimethoprim, but it's going to do that in humans, right? So it's actually going to be used more as an immune suppressant agent because, again, if I'm inhibiting the building blocks of my DNA, right, that being the nucleotides in some way, there's going to be a global impact, particularly on the lymphocytes, which rely very heavily on DNA synthesis, right? And we can see that down here, inhibits dihydrofolate reductase. Again, if I'm inhibiting dihydrofolate reductase and I'm interrupting purine and pyrimidine synthesis in doing this, potentially, that's going to have an effect on ability to undergo DNA synthesis. Okay, so that's what methotrexate does. Now, remember, trimethoprim is essentially doing this in bacteria. Okay, so when we talk about like trimethoprim sulfamethoxazole, the trimethoprim component is inhibiting the same enzyme, but just in bacteria. So it's preventing bacterial DNA synthesis, right? So that's why it's an antibiotic. Methotrexate is doing this in humans. So that's curbing the immune response in humans, right, by inhibiting this enzyme, because now the person that's being treated with methotrexate, right, they can't mount a very robust immune response because they don't have the building blocks to do so. Like I said, we'll go through all the details of the pathway on this in the biochemistry section. All right, and again, high yield adverse effects. Pancytopenia is a big one. Again, this all has to do with the fact that we're in some ways inhibiting the production of the building blocks of DNA synthesis, with which these cells very heavily rely on. Now, one last thing on here, or two last things I want to talk about. The first one is when you give a patient allopurinol. So kind of remember what allopurinol does here. So allopurinol, remember, there's a purine salvage pathway, and we can also break down these purines, right? So guanine can get broken down by xanthine oxidase, okay, by xanthine oxidase to form xanthine. This xanthine can then get broken down again by the same enzyme to form uric acid, and then we can excrete this in the urine. Now, this can also happen with hypoxanthine, and again, I don't want to go into all the details per se in this video because the video will be quite long, but what we want to talk about here is, remember, this xanthine oxidase can get inhibited by allopurinol. Okay, and the concept here is I don't want a whole bunch of uric acid around if I have a patient that has gout. Okay, so allopurinol is frequently used as a maintenance therapy to kind of control the uric acid levels. What you have to understand here is that this 6-mercaptopurine can essentially end up forming hypoxanthine, right, as we start to break it down. The concept here is that this 6-mercaptopurine is kind of, in some ways, looks like an analog to things like guanine or hypoxanthine. And so the 6-mercaptopurine, right, I'm just going to put 6-MP here, this also gets broken down by xanthine oxidase. If I'm inhibiting my xanthine oxidase, what do you think is going to happen to this 6-mercaptopurine level? It's going to go up. 6-mercaptopurine levels will go up if I can't break it down. And you might be saying, well, will guanine levels and hypoxanthine levels go up? Potentially, but a lot of this will probably go through the purine salvage pathway, okay? So they'll probably go through the purine salvage pathway and form IMP, okay? And again, we'll go through all of that in the biochem section. The point here is that you get this buildup of 6-mercaptopurine, which is not going to necessarily go to form IMP. Instead, it's going to build up to potentially toxic levels, right? And inhibit too much of your PRPP aminotransferase. So just remember, if you have a patient in a board question on allopurinol and they're getting 6-mercaptopurine, there can be some serious side effects to that. And there's a lot of different ways they can word that, but you just have to remember that these two are associated in that way, in the sense that 6-mercaptopurine is broken down by xanthine oxidase, much like hypoxanthine and guanine. Finally, the last thing on here, just remember mycophenolate being associated with invasive CMV infections. So this is, again, an opportunistic infection that would, kind of push you in the direction of mycophenolate. So just kind of keep that in mind. All right, so we made it to the biologic immunotherapy. This slide has a little bit more memorization than any of the other slides. Now, one thing I might recommend doing, making sure you go through a lot of the immunobites and a lot of the flashcards to really make sure that you understand what each of these monoclonal antibodies are doing. Because more and more as time goes on, these monoclonals are getting asked about more and more frequently. Now, again, you don't necessarily have to know about management, okay, but there are certain targets you really want to be familiar with and certain adverse effects in some situations you want to be familiar with. So the biggest thing here for step 1 purposes is going to be knowing the names and their targets. If you can add on another layer to that, knowing the adverse effects. The last thing I would know, unless I highlighted in red here, is going to be the indication. Okay, so we'll go through this in just a second. I just want to make sure we talk about these TNF inhibitors, which also have some monoclonal antibodies, and then we'll jump into the immunologics here. Now remember, TNF, especially TNF alpha, right? We're thinking interleukin 1, interleukin 6, and TNF alpha, kind of as that initial acute inflammatory response, right? These are our acute inflammatory mediators that we talked about very early on in immunology section. So essentially what we're doing is we're inhibiting that TNF alpha response, right? Part of that acute inflammatory response. Okay, so the medications that can do this, there's a few different ones. Infliximab, okay, this is kind of like the classic one. Now this one is a chimeric anti-TNF antibody. It's not humanized. Okay, so it's been around for a while, which you can see here. And again, these, I would say in general, the adalimumab is probably the highest yield. But the point is you just have to remember these are humanized anti-TNF antibodies versus infliximab, which is chimeric. The one that gets confusing here is this etanercept, because unlike these other monoclonal antibodies, it's going to be a fusion protein that's kind of just floating around in the blood looking to bind up TNF, alpha or beta. Okay, so let's just talk about monoclonal antibodies really quickly here. So again, remember, monoclonal antibodies, we're talking about some antibody, again, that has a Fab portion and an FC portion. Okay, so you can imagine if I bind to a receptor, right, if I have some receptor, just like we saw with interleukin-2 and basiliximab, right, that antibody can bind to the receptor and essentially block it, just like we see with myasthenia gravis. And so that's basically what we're talking about with monoclonal antibodies. Notice how they all end in MOB, right? Monoclonal antibodies. But when you look at the name here of etanercept, you can see that it doesn't have that same suffix. Let's just say that we have some TNF alpha in the blood. If I block its receptor with an antibody, then the TNF can't bind to it. Now, the other thing I can do besides blocking the receptor is I can kind of create a receptor to just float around in the bloodstream, right? A soluble receptor that can basically cause the TNF alpha in the patient to bind to my receptor. Okay, so I can essentially eat up a lot of the TNF alpha, so I can decrease the level. So essentially, I'm going to say that I have this receptor with the TNF alpha bound to it. So now this TNF alpha can't go binding to the receptors in my host. Instead, it's bound to my drug. And that drug is etanercept. Oversimplification, but that's really all you have to know. Okay, the point is it's not a monoclonal antibody. It's essentially me putting a receptor in the patient that's just soluble, floating around, binding up the patient's TNF alpha or TNF beta. Now, the high yield side effects here to remember is going to be reactivation of tuberculosis. Now, remember that tuberculosis, right, you can have a latent stage of tuberculosis or you can have active tuberculosis. The difference here, right, if I had latent tuberculosis, you might do a study on me like a tuberculin skin test, and it's probably going to be positive. You can do also the interferon gamma release assay, which we'll talk about in the micro section. But in both of those situations, if I have latent tuberculosis, that means my body's fighting TB, it's just not active, right? I'm not symptomatic, I'm not contagious, but I have TB and I need to be treated for it. Okay, so we can screen patients for that and say, hey, this patient might not be contagious, they might not have an active infection, but the patient needs to be treated for tuberculosis before we start one of these medications. Well, why is that? Well, if I start one of these medications, right, and I start inhibiting, right, using the TNF alpha inhibitors, I start inhibiting the inflammatory response in this patient, and they're trying to fight off this TB infection. They have this latent TB infection. That TB infection could become active. And now I have a problem, right? So in the situations where you want to start a TNF alpha inhibitor, you should always be screening these patients for tuberculosis. Now remember what active tuberculosis is, right? If this infection is active, those patients will tend to be symptomatic, right? They'll be cough, they'll have potentially hemoptysis, chest x-ray findings will be positive, they'll be contagious, right? That's an active TB infection, okay, as opposed to a latent one where you don't really see the symptoms, but you still test positive. And the last thing I want to say about these, I didn't really include this here. This is more medium yield, but remember too, drug-induced lupus. So, I talked about this before in some of the previous sections, but again, the big three for drug-induced lupus, definitely going to be procainamide, okay, procainamide, hydralazine, and isoniazid, okay? So when you think about drug-induced lupus and you think about anti-histone antibodies, right? When you think about this, you need to associate this with these three drugs. Now, if you're going for bonus points, you say, okay, I got that all down, no problem. I have a little bit of extra room in my brain. Then you can add in this fourth one. And the fourth one is going to be TNF alpha inhibitors. These drugs that we're talking about here can also cause drug-induced lupus. Are they as classically asked about in this setting? Not really. But remember, they can cause these patients to have drug-induced lupus, and you'll pick that up with antihistone antibodies. It's going to be a lupus-like picture, usually on one of these medications. Okay, that just an added layer if you're feeling really comfortable with that. But again, it's not one of my big three. My big three for drug-induced lupus: procainamide, hydralazine, isoniazid. All right, we're going to clean this thing up and go through the biologics here. So, like I said, for each of these, I want you to make sure you know the target. The target is the most important thing. So natalizumab, the target alpha-4 integrin. Okay, this is sometimes called Tysabri in real life, and the natalizumab is primarily going to be used for MS. And again, this is not an exhaustive list, right? A lot of these can be used 10 different diseases potentially. So, it's going to depend. But again, there are some high yield ones to know. So MS is very classic for this, usually a very severe MS. You don't go around giving natalizumab to everybody because the concern is it can cause reactivation of the JC virus. Okay, and this can lead to progressive multifocal leukoencephalopathy. And we talk about this a little bit in the neurology section. The reason for this is because you're inhibiting the immune response. In MS, you have autoimmune destruction of some of the oligodendrocytes. And so you're essentially trying to curb that response. And you do that by targeting alpha-4 integrin. Alpha-4 integrin is particularly important for white blood cell adhesion. Things like neutrophils have to get to the site of wherever this inflammation is happening so they can dump their granules and can cause pretty significant inflammation, right? And so the idea here is you don't want those white blood cells to bind to the integrins, to have rolling adhesion, all the things that we talked about in this unit. You don't want that to happen. And so you give a drug like natalizumab to prevent the white blood cells from getting to that location. All right, rituximab CD20. What's CD20? What do you think about when you see CD20? You think about B cells, right? That was a classic B cell marker. You don't really have to know a lot of the indications for rituximab because, like I said, this is another one where there's so many diseases that can be used for. But the big thing I want you to remember is reactivation of JC virus, again, with rituximab. What is the patient going to present with if they have reactivation of JC virus? Well, there's some classic findings that we talked about in the neurology section on CT scans, but just in general, I mean, you're looking for things like new focal neurologic deficits, new weakness, seizures, right, headaches, vision deficits. They might be mistaken for having a stroke potentially, right? These are all things you might be looking for. All right, palivizumab is going to be very classic for the target of the RSV-F protein, and so we're going to see this a lot given in infants particularly as RSV prophylaxis. We're using it to prevent RSV. You might be saying, well, how is that? Think of this as a passive antibody. When we talked about things like tetanus immunoglobulin, right? Why do you give somebody that? Well, you're giving them passive immunity. You're giving them the antibody. You're not causing a response to happen. You're literally just giving somebody the antibody. Or the same thing with mom and the infant. Mom gives antibodies to the infant for that first 6 months. So we're essentially giving the antibody to RSV. The concern is that certain patients are at really high risk for getting RSV. Premature infants is probably at the top of your list, right? Also, infants with congenital heart disease, right, would also be very classic. These infants are at a lot higher risk of getting RSV and having a really hard time fighting the infection off. And so usually we'll give them antibodies, right, passively against RSV, the RSV-F protein specifically, for an extended period of time. Omalizumab, we're talking about soluble IgE as the target. Okay, so soluble IgE, the idea here is this is IgE that's just floating around in the blood. Remember, we talked about mast cells, right, on the surface of mast cells in patients that have allergic reactions. This can also be a basophil, by the way. On the surface, we have this Fc epsilon receptor, right? So we have this receptor on the surface of mast cells that can essentially bind the Fc portion of IgE, right? So this patient might have some IgE that's binding using its Fc portion to the Fc epsilon receptor, right? Here's the Fab portion. And then when an antigen comes into the blood, right, that we've been exposed to before and binds to this IgE, we get cross-linking, right? And then we get degranulation of the mast cell. The idea here is with omalizumab is you're binding up. So if there's IgE in the bloodstream, eventually it might end up on one of these Fc epsilon receptors. And so the idea here is with this antibody, you essentially want to bind up all of the IgE using the omalizumab, binding to its Fc portion to prevent it from binding to mast cells. That's the concept. And when would this be used? Well, patients that have pretty severe allergic reactions. Okay, severe allergic reactions, particularly in the setting of asthma. Trastuzumab is going to bind to the HER2 new receptor. We'll talk about this more in the onc section. And again, we talked about in the cardiology section a little bit different types of cardiomyopathy. The trastuzumab is very classically associated with the dilated cardiomyopathy that's reversible when you discontinue the drug. And it can even be a low dose of this, right? You can use a really low dose can still cause this cardiomyopathy and you have to discontinue it to stop it. This is kind of juxtaposed to anthracyclines, which are cumulative dose dependent for cardiomyopathy, right? So again, talked about this in the cardiomyopathy video. Eculizumab is targeting C5. This is one that you really want to remember the indication, right? Paroxysmal nocturnal hemoglobinuria. We talked about this a little bit already in this section. I won't go into too much detail, but remember, there are certain inhibitors, CD55, which is going to be DAF, right? And then also CD59, which is the membrane inhibitor of reactive lysis. And these are going to be on the surface of our red blood cells, and they're going to prevent our own complement from destroying our red blood cells. When we lose these markers, right, we're losing these complement factor inhibitors. Now our cells are up for grabs, right? Complement can bind there and destroy our own cells. And so we can give C5 inhibitors to essentially inhibit complement from destroying our own cells. But the problem is now you end up with encapsulated bacterial infections because you can't use complement, right? So that's commonly used to destroy a lot of these encapsulated bugs. And so you have to make sure these patients are up to date on their vaccinations. So bevacizumab is going to be a VEGF inhibitor, right? It's going to target the vascular endothelial growth factor. This is classically going to be used for colorectal cancers, not particularly high yield for step 1. And this can cause GI bleeding. Again, not particularly high yield. These two here are going to be EGFR inhibitors. Again, not particularly high yield. Just know the associated target. That's the big thing that you have to remember. Denosumab is going to be a rank L inhibitor. This is essentially going to be used to prevent the osteoclastic breakdown of bone, and that's going to be important for patients that have osteoporosis, right? You don't want them breaking down more bone. The idea is you're inhibiting that process to some degree so that these patients can have stronger bones, right? So less osteoclastic breakdown, but because of that, there's going to be less calcium going in the blood. So hypocalcemia is a major side effect. Interestingly, there's a lot of studies on this. Patients that are on these for a long time can actually be more prone to things like femur fractures. So you have to kind of cycle these patients off. So definitely certain bone fractures is actually one of the major adverse effects, although that might be a little bit beyond the scope of step 1. Pembrolizumab is a big one when you're talking about PD-1 inhibitors, which we'll talk about in a lot more detail in step 2 in particular, but again, associated with many cancers, just know the target. Abciximab is going to be your GP2B3A receptor. We'll talk about this again in the hemonc section. Very much used by a lot of the cardiologists prior to PCI, usually 24 hours before PCI. Remember, these GP2B3A receptors are essentially going to be on the surface of platelets that fibrinogen can bind to. When you inhibit that, you're going to eliminate essentially fibrinogen binding and essentially inhibit platelet aggregation. So the risk here is going to be bleeding. And again, like I said, we'll talk about this in the hemonc section. The last few on here, again, just knowing the markers is going to be important. I'll let you kind of look through that. This one in particular is very classic for psoriasis. So I would also remember, I'd put this in kind of like your high yield bucket. Ustekinumab, very classic for psoriasis and inhibition of interleukin 12 and interleukin 23. But that's going to do it for the immunology section. I hope y'all enjoyed this series. A lot of information here. Hopefully it's a little bit more digestible now.
Take 15 seconds to pause the video, read the question, and then we will go through the answer. Pretty challenging question here overall, just because, in some situations you're going to get questions like this where there's a lot of information and you have to efficiently get to the right answer. Questions like this are typically equally weighted to questions that are a little bit more straightforward. So it would be a bad idea to mark questions like this on the real thing. But anyway, let's get into this a little bit. So we have a 57-year-old male with past medical history of acute lymphoblastic leukemia. Previously treated with chemotherapy, presents to the emergency department with abdominal pain and diarrhea. He reports developing acute onset stabbing abdominal pain and chills a few hours prior to admission. This is pretty interesting. So he has chills, stabbing abdominal pain, but this all started, I think this is the key point actually here, a few hours prior to admission. So we're just going to note that. Interesting past medical history here. He also endorses 2 episodes of non-bloody emesis en route to the hospital. He's been hospitalized 4 times over the past 2 months due to numerous infections requiring antibiotics and antifungal medications after receiving a bone marrow allograft from a family donor. Okay, so this is a situation, again, when you're reading through these stems, what is something that jumps out at you, right? When you're reading through these stems, there's a lot of information. You're looking for that one thing that kind of calls your attention to something, right? Now, remember what we talked about in this unit. When you see bone marrow transplants or you see hematopoietic stem cell transplants, when you see that, okay, especially, right, these are the allogeneic, right? So this is getting transferred, again, from a family donor that probably has similar HLA compatibility. It doesn't mean there's not going to be HLA incompatibility, but the key thing though, right, if we're just talking about organ transplants versus bone marrow transplants, when I see bone marrow transplant, when I see hematopoietic stem cell transplants, right, when I see this, I'm going to start to think about a graft versus host disease right off the bat, right? Because usually in a board question, when they test you on graft versus host disease, they're usually going to do it with hematopoietic stem cell transplants, bone marrow allografts. Very, very classic for this type of presentation. Now, they can also do this with a liver transplant, which we kind of talked about can present slightly differently in terms of like the liver enzymes and that sort of thing, which I'll get to in a second. But the point is, when you see this, that should zone you in. It doesn't mean that it's going to ask about graft versus host disease, but immediately my radar is now up. Graft versus host disease. This patient's on medications that consist of mycophenolate, immunosuppressant, prednisone, right, can suppress the immune system, cyclosporine, immunosuppressant, right? So this patient has all these infections, right, probably related to the fact that they're on immunosuppression because they had a bone marrow transplant. Oh, and by the way, they also had chemotherapy recently for this history of acute lymphoblastic leukemia. Okay, so far, I feel like I'm in a good place reading the stem. The patient denies any history of alcohol, tobacco use, or recent travel. Okay, all right, so let's keep going here. So the patient's tachycardic with a heart rate of 108, vitals are otherwise stable. This is an important line, right? If you're thinking about, what's causing this patient's problems. Well, he's got all these infections from before. Is this another infection? Usually in a board question, if it's an infection, they're usually going to say, hey, the patient's febrile, or they might give them a white count, which I'm just kind of jumping ahead here. If there's a leukopenia, it could mean infection too. But, usually they'll tell you something about the patient has a fever, and you might be saying, well, why is the patient tachycardic? I mean, it could be the patient's just in pain, right? The patient developed acute onset stabbing abdominal pain a few hours earlier. Tachycardia, in my opinion, especially from a clinical perspective, is probably related to that, but we're going to get into a little bit more detail here. So physical exam reveals jaundice, maculopapular rash over the dorsum of the hands bilaterally. Let's stop right there. That's particularly high yield. Again, what are the key things I'm looking for? I already have graft versus host disease on my radar just from reading that the patient had a bone marrow allograft from a family donor. Now you tell me there's a maculopapular rash that the patient has. Remember, maculopapular rash is a classic descriptor of something we would see in a graft versus host disease patient. Why do we see that? Well, it's because the graft or the donor T cells, right, which you can see the right answer here, the donor T cells are attacking different organs in our host. One of those organs is the skin, right? The skin's getting attacked. The liver classically gets attacked. So remember, in graft versus host disease, the three things I want you to think about that are going to get attacked: the skin, which is where we get this maculopapular rash, right? The other organ here we said is the liver, and the other organ here sometimes will be the intestines. Okay, so the skin, the liver, intestines. Now, if the graft is the liver, though, remember, then it could present a little bit differently. But in general, if it's a bone marrow transplant, skin, liver, intestines is what I'm looking for. So how does the skin present? Maculopapular rash. So this patient also has tenderness to palpation. Well, that could be because there might be inflammation in the intestines, right? I'd be looking for potentially like hepatomegaly would also be very classic. This tenderness to palpation is in the left and right upper quadrants. You can also affect the spleen, right? Lymphadenopathy is absent. Now, this is an interesting point, and I don't think we're getting tested on this directly, but not to get too off track, why is lymphadenopathy mentioned, right? Really quickly here. So this patient had acute lymphoblastic leukemia. Okay, then the patient went through chemotherapy, right? So they went through chemotherapy, and now the patient had for more definitive management, right? They had a hematopoietic stem cell transplant or bone marrow allograft from a family donor. Okay, now the fact that they have this, though, they have to be probably placed on some immunosuppressive therapy, right? They're going to be on some immunosuppressive therapy so we don't get rejection. Okay, so the thing that happens here because of this that you have to kind of understand is the complications, right? So it could be that this patient potentially develops an infection, right? Maybe an opportunistic infection, maybe a CMV or HIV, right? They can get some form of infection. Now, one of these infections could be a Kaposi sarcoma, right? So HHV8 is classic, Epstein-Barr virus is classic, right? HIV, CMV. All of these can sometimes get asked about in a patient on immunosuppressive therapy after transplant. Remember, though, that these infections, a lot of them, like a Kaposi sarcoma, can go on to then lead to cancer, right, or malignancy, right? So a Kaposi sarcoma, which is herpes virus 8, human herpes virus 8, HHV8, this Kaposi sarcoma, I'll just put KS for Kaposi sarcoma, can then go on to have some oncogenic potential. Now, the same is true for Epstein-Barr virus, EBV. This can go on, and the classic one that sometimes gets asked about with this is going to be like a Burkitt lymphoma. Or in general, we can just put a non-Hodgkin's lymphoma, which we're going to talk about all of this in the hemonc section. I don't want to get too off track, but the point that I'm trying to make here is that these patients can get infections with some of these more opportunistic organisms. Patients that are on immunosuppressive therapy are at higher risk for this. This is why, most likely, they're mentioning lymphadenopathy here, because if the patient had lymphadenopathy, I'm going to want to biopsy that thing. I'm going to be thinking, now I'm a little bit more worried about some kind of malignancy, potentially a lymphoma, now from this immunosuppressive therapy that led to an infection with higher oncogenic potential. All right, we're off the detour, back on the main road here. So serum laboratory studies are shown below. We'll go through these in a second. Let's just keep reading. So, okay, CT scan of the abdomen and pelvis reveals thickening of the ascending colon. I would contribute this mostly to the intestinal inflammation from the graft-versus-host disease, but it could be more of an infectious colitis versus an inflammatory one from the graft-versus-host disease. A liver biopsy is subsequently performed. Remember what I told you if you've been watching this series, whenever you see biopsy in any question, that usually is one of the most important lines in the vignette because it's going to tell you something definitive. Now, you might not always know what the biopsy means, but it's usually going to give you some key information. Now, in our situation here, the biopsy is telling us that this is of the liver, okay? And it's revealing a moderate lymphocytic infiltration surrounding vacuolar steatosis and perisinusoidal fibrosis. So sometimes when you read stuff like this, it's a little intimidating, right? Like, what are they talking about? So when you see stuff like this and you're trying to figure this out, the key takeaway here is that there's lymphocytic infiltration. So we know that there's an inflammatory infiltrate here that's largely lymphocytic, right? These other things, the fibrosis to me kind of reminds me almost more of like a chronic process, even though this patient just started to have this pain. And then I also see this, there's no neoplastic cells are observed on biopsy. It doesn't seem like the question writers are really pushing us at all in the way of any kind of malignancy. All right, which of the following best explains the mechanism for this patient's pathology? Okay, let's just go through the labs really quick, and then we'll kind of talk about these options. So the leukocyte count is actually a little bit low here, which is actually not uncommon in graft-versus-host disease. In fact, you can have a pancytopenia in graft-versus-host disease. You could say, okay, well, the leukocyte count's a little low. Am I thinking more about an infection? Really, there's not any real indication in this question that there's an infection, particularly if we're thinking about these classic kind of viruses that are asked about. If you look at the HIV load, it's undetectable. CMV load's undetectable. Viral hep serologies, sometimes they'll give you like specific serologies. In this case, there's a lot of stuff being mentioned, and I think they just went with, hey, all of these are negative. Herpes serologies are also negative. If we look at the liver enzymes, the ALT is 477, AST 387, so these are definitely going to be elevated. They're not in like the shock liver range or the acute hepatitis range, right? If you're thinking like viral hepatitis, or you're thinking like a shock liver, which we'll talk about more in the GI and infectious disease sections, but in those situations, these labs will tend to be over 1,000. So there's some inflammation going on here in the liver, most likely, though, that's causing this transaminitis, especially based on this infiltration that we see. Total bilirubin's also quite elevated, might explain some of the jaundice. The amylase and lipase are normal, right? So we're not thinking as much of a pancreatic process, potentially. Thyroid stimulating hormone in the reference range. Blood cultures, no growth for bacteria or fungi. Okay, so that's kind of another key point. So, they're really not pushing us in any way towards a infectious cause. And interestingly, they also have an anti-double-stranded DNA antibody here, which is negative. Again, there are some key things, especially the things in red here, that I'm really looking at. And, when I'm reading a question on the real thing and I only have one color highlighter to use, I'll probably just use the yellow on the things that really count, right? The bone marrow allograft, the lymphocytic infiltrate, the maculopapular rash, right? Those are the big things that stood out to me. Let's just go through some of the options here. Now, so if you're kind of stuck between these, remember, the key thing you have to understand about graft-versus-host disease, and we go through this all in the dedicated video on this, when you're talking about graft-versus-host disease, so we have the donor graft, right? So the donor is going to give this graft, I'll just put G for graft, to the host. So the donor is going to give that graft to the host. Now that graft, remember, contains lymphocytes. And so what's happening is when I give this to the host, remember in this case it was a bone marrow transplant, so this graft went to the host. We'll just draw a little bone in here with the graft. Okay, so here's my graft with all the lymphocytes on it. And those lymphocytes, right, these T cells, largely T cells, are going to get out into the systemic circulation and eventually, at some point, can cause pathology. And we already said, where are they going to target? They're going to target the skin, liver, intestines. They could really target any organ, but these are the three that are classically asked about. And so if they go to the skin, right, what do we get? We can get a maculopapular rash, right? If they go to the liver, we can get an inflammatory reaction from the liver, right? So we can get a transaminitis potentially. We can have right upper quadrant pain or tenderness or hepatomegaly, right? These would all be kind of classic presenting symptoms. They can go to the intestines too. And we also saw some of that. We saw that there was some thickening of the ascending colon that's probably related to this, right? So these T cells are kind of branching out from the donor and they're attacking the host tissue. For that reason, this is a donor T cell mediated cytotoxicity. It's the donor cells that are causing the problem in this patient with graft-versus-host disease. Now you might be saying, well, how do I know that it's not the host T cells? How do I know the answer is not E? The host T cell mediated cytotoxicity would be more classic, right? If I had some organ, right? So again, here's my donor, okay? And in this case, we're going to give some graft over to the host. And let's just say that this is in the liver, for example. Okay, so here's my host. And let's just say that I give this graft over to this patient's liver,
right? So here's my graft. And in the example of E, what we're talking about is the host's lymphocytes attacking the graft. Okay, so that's what E is talking about. Now remember, this is going to be more classic for an acute rejection, as we would call it, or acute transplant rejection. And we said this can happen a few different ways, right? The donor MHC1 antigens can get basically attacked by the CD8 positive T cells of the host, or the donor antigens that are MHC class 2 can get recognized by CD4 positive T cells, turn into T helper 1 cells, activate interferon gamma. Macrophages are brought to the site of the graft to destroy it. So we went through all of this in the videos already, but this would be an example of more of a host T cell mediated cytotoxicity because it's the host's lymphocytes that are doing the damage here. And again, in this situation, we have a bone marrow transplant, which again automatically calls my attention to graft versus host disease. And then the fact that we have all the classic presenting signs would make this a better explanation in terms of a donor T cell mediated cytotoxicity versus the standard kind of transplant rejection we would see with the host T cell mediated cytotoxicity. C, antibody mediated graft ischemia. So what's this referring to? So this would be very classic for a patient that has a hyperacute rejection. It's usually in the first 48 hours, could be in minutes as soon as they put the graft in. But essentially, it's because the host has pre-made antibodies that as soon as you put that donor graft in, those preformed antibodies are already targeting that graft for destruction. Usually, if this is asked about in a question, it has a lot to do with ABO incompatibility. And you get like immediate thrombosis of the vessels of that graft, or at least pretty quickly you get thrombosis of the vessels, and then you'll see graft ischemia. And so that's very classic as a type 2 hypersensitivity reaction, right? Because the antibodies are preformed, they're mediating the destruction via complement of the graft. Whereas if we're talking about like a graft versus host disease, right? So graft versus host disease, this would be more of a type 4 hypersensitivity because it's a cell-mediated cytotoxicity. The same thing for an acute rejection, right? In an acute rejection, again, type 4 hypersensitivity, right? Because in acute rejection, it's host T cells that are mediating the cytotoxicity. Option B here, host RNA polymerase transcription of viral proteins. If we're talking about something like CMV, HIV, right? These viral pathogens can essentially hijack our cells and cause our RNA polymerase to then transcribe viral proteins for them, right? So if this patient had a detectable viral load, for example, we might be suspecting this a little bit more, but I don't think there's really enough information to potentially make this the best answer because all of these viral loads are negative, okay? So certainly that could be something you see in this patient. These patients are at higher risk for that because they're on immunosuppressive therapy, but doesn't seem very classic, especially based on all of the more classic findings we see with graft versus host disease. Latency-associated nuclear antigen binding of P53. A lot of times in board questions, there'll be an answer on there that's completely something you probably have never seen before. Latency-associated nuclear antigen is something that we see classically with HHV8, human herpes virus 8, which is, remember, when we're talking about Kaposi sarcoma. Okay, so Kaposi sarcoma. Now, the thing that we have to remember about Kaposi sarcoma is that you can actually still have skin lesions there, but it's usually not this maculopapular rash. It's usually more of like a purple, pink plaque that you're going to get, and it could bleed and it can ulcerate. And again, patients that have Kaposi sarcoma are these patients that are on immunosuppressive therapy. They get, an infection or reactivation of HHV8, and this Kaposi sarcoma can lead to oncogenic potential, right? And so that's what you're primarily concerned about. And there's really no clear features of Kaposi sarcoma that I would wager to say that we would expect to see here. Kaposi sarcoma, you can sometimes have neoplastic cells, you can have lymphadenopathy, right? These patients are at higher risk for lymphomas, like a big one would be a diffuse B cell lymphoma. Again, we'll talk about all of this in the hemonc section in a little bit more detail. But so how does Kaposi sarcoma have this oncogenic potential? Well, for one, it can bind P53, right? Remember, P53 is a tumor suppressor gene, so it can basically inhibit the function of P53. And the other thing it can do in cells that it's infecting, it can inhibit the FAS-induced apoptotic pathways that would destroy those infected cells. Okay, and so then these cells live longer, right? You get rid of your tumor suppressors, and so you start to kind of transition into this direction of a more malignant process, right? And especially if you're immunosuppressed, you have an even harder time fighting this virus. But again, that's what this is referring to. Again, not completely relevant to what's happening with our patient, although it's certainly something that we would be concerned about in a patient on immunosuppressive therapy. Big picture, the thing that you want to look for, if you're looking at bone marrow transplants or hematopoietic stem cell transplants or even sometimes liver transplants, always keep graft versus host disease in the back of your mind. Remember that it classically involves the skin, liver, intestines. And again, when you get to these larger stems with all this information, just look for something that really stands out. In this case, there were some really specific things that we talked about that took us down the pathway of graft versus host disease.